Health will come to order. I want to start off by welcoming all of the new members that are on our Health Subcommittee, and I look forward to working with our ranking member, Devin Nunes. I think we can have a productive beginning to this Congress. I have some brief opening remarks, and then I know Mr. Nunes will have some. We're very fortunate to have the panel that we do this morning to continue the exploration of prescription drug issues that we talked about only a couple of weeks ago here in the full committee. I was encouraged at that hearing to hear a number of comments from colleagues from both parties about the medication problems that each of us has been hearing from our constituents about. Today we have a special focus on the role that competition can play in bringing down soaring drug prices and on the multiple barriers deliberately constructed by the industry to prevent competition from working effectively. One such solution is ending the pay-for-delay settlements where brand name and generic manufacturers agree to anti-competitive deals that keep competition off the market. I've introduced legislation last session and again this time to prohibit this kind of behavior and to try to encourage more competition. I hope that this is an area that we can find common ground on. Our witnesses last month and again today offer more evidence of the reality that so many Americans confront where essential medicines that are there but they cannot afford them. And they either get those medicines with great difficulty by jeopardizing their financial health or they do without the medicines. Prices for the most commonly prescribed brand drugs under Medicare Part D have soared up to 10 times the rate of inflation. And this is a problem not only for the individuals, but for American taxpayers. The Medicare trustees expect drug spending to nearly double over the next decade. Unfortunately, there is no miracle cure for price gouging. While, as our witnesses explain, Congress should be engaged in a number of actions, I believe some of these are within our committee's jurisdiction that we'll hear about today, and some of them are informative but a little outside of our jurisdiction and require working with colleagues on other committees. I believe that the most important of those measures is to use bargaining power to lower prices for those who rely on Medicare, much the same way that the Veterans Administration has done for years on behalf of our veterans. When over 15 years ago, the Medicare prescription drug program, which was voted on in this committee, was narrowly forced through the House in the middle of the night after considerable arm twisting, one of the provisions that was inserted was a notable section that provided a complete prohibition against Medicare negotiation of drug prices. In 2007, every Democrat and 24 Republicans approved legislation to repeal that costly limitation, but not surprisingly, it was blocked in the Senate. Medicare negotiation is also the approach that candidate Trump recommended to save hundreds of billions of dollars through what he called bidding. And he pointed out the reason that we don't do this is, quote, because of the drug companies. Importantly, that 2007 bill lacked a mechanism for addressing what happens when negotiation is unsuccessful. The most common way of addressing that situation for a manufacturer who will not negotiate is to simply refuse to cover the drug, to exclude it from the list of approved drugs or what's called the formulary. That, of course, produces claims that a life-saving medication is being denied to someone who is relying on Medicare. And that's basically the argument that fills the multicolored ads in every Capitol Hill newspaper almost daily against the Trump administration's pending Part D proposal. So I've advanced an alternative to that, which we'll hear more about today, as a way of assuring that every drug is available, but some competition can hopefully bring the price down. Unwilling to yield their monopoly power, we also hear a number of scare tactics that insist there is no way to have reasonable prices and still encourage essential innovation. Our witnesses today can respond to those arguments. I think all of us want to encourage cures and treatments for dread diseases before we get them ourselves or a member of our family or a loved one or a friend. Despite the immense lobbying power, despite government-funded research, despite monopoly profits, Big Pharma, I believe, has actually not done a very good job on innovating and providing the medications that we need. It's seldom worried with a competitor, and so monopolies and oligopolies are not known for their innovative spirit. They're not known for that quality in any industry. Over the last decade, 74% of all pharmaceutical patent applications were not for new innovative cures, but were for modifying existing drugs, which often took the form of what's referred to as evergreening, simply to protect monopoly pricing, not to provide new drugs. And taxpayers have been funding a significant amount of this research. From 2010 to 2016, every single newly approved drug relied on taxpayer-funded research. The taxpayer pays for the research, the government approves the monopoly, and unlike other modern countries, the pharmaceutical company faces little or no restraint on the prices that it charges. During the last year, Big Pharma has changed its approach from denying that there is any problem at all to pointing the finger at everyone else in the supply chain. Strangely, I've heard Secretary Azar, who I hope will be before our full committee over the budget in coming months, claim that Medicare negotiation is not necessary because Part D insurers are already so adept at negotiating, and then turn around and blame price hikes on the prescription benefit managers who do the negotiating. We do need to examine the practices of these PBMs, and they may well be contributing to some of the high prices experienced by consumers across the country. But without addressing the manufacturer who sets the price, I believe we'll still have too many people having to cut their pills when prices are not cut. I believe we have a responsibility to ensure that patients come first and that it is their health and livelihoods that are the only thing that is non-negotiable. Unaffordability and inaccessibility are not the unavoidable side effects of innovation. They're a result of unrestrained monopoly power. I thank all of our witnesses for joining us today to examine these issues and welcome the comments of our ranking member, Mr. Nunes.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today. A few weeks ago, we sat in this room and started a good conversation about the broken incentives in the Medicare program. We committed to work together on a bipartisan basis to lower out-of-pocket health care costs for Americans by cracking down on overpriced drugs, empowering patients to choose the most affordable medicines for them, and eliminating the incentives in Medicare that reward bad actors and lead to higher prices. However, I'm worried that some of the ideas advocated by my friends on the other side of the aisle may go too far. We haven't yet had a hearing on the Democrats' radical plan to outlaw the private insurance Americans get at work, but we do have an opportunity today to talk about one of the planks of the plan, the confiscation of intellectual property if a manufacturer rejects the best offer of a Washington, D.C. bureaucrat. That sort of policy, the seizure of medicines by an unhappy government agent, is best left to socialist regimes, not here in the United States of America. Yet there are over 100 members of the majority party that do support it. It's a little shocking, and I want to be clear that Republicans oppose this control and confiscate agenda. Republicans are fighting to ensure Americans have more choices, not less, and that the pipeline of innovation for cures continues. There is no silver bullet addressing the bad actors in the pharmaceutical industry, but I think we can work to get the incentives right. I pose three questions today. The first being, why do we have a system that rewards manufacturers who charge the highest price in a drug class? Second, why do we have a system that puts the taxpayers on the hook for bailing out insurance plans? And third, why do we have a system that makes cancer patients pay double for chemo based on where they get their treatment? I hope our witnesses will be able to spend their time today answering these three questions, not walking us through unprecedented policies like compulsory licensing, which will squash hopes for future medical breakthroughs. I am hopeful that we can reach a bipartisan agreement, bipartisan legislation that can pass the House and the Senate and get signed into law by President Trump. I now yield back the balance of my time.
Thank you so much. Again, thank you so very much for your comments, and I believe you set up the opportunity for a considerable debate on those issues, and to hear from our distinguished panel, I would like to welcome first Robin Feldman. She is the Arthur J. Goldberg Distinguished Professor of Law and Director of the Center for Innovation at the University of California, Hastings. She is a leading expert in access to medicines and innovation law. I think I'll just introduce each of you as you come up for consideration. So, Professor Feldman, if you would proceed, please.
Thank you, Chairman Doggett, and esteemed members of the committee. I am honored to be here today to address an issue that is causing real pain for patients and for those who are trying to help them. So prescription drug prices are soaring. In the 5 years between 2011 and 2015, Medicare spending for brand-name drugs rose 62%, and that's even taking into account rebates. That's a hefty rise. It does not take sophisticated economics to know that at some point, these price increases are unsustainable, and it's tough to tell patients in Chicago to pay thousands of dollars for a drug when their cousin in Toronto pays $30. So what's going on? Well, quite simply, our regulatory and payment systems allow drug companies to drive patients into more expensive drugs while preventing cheaper drugs from gaining a foothold in the market. At the center lie the intermediaries known as PBMs, who negotiate drug prices. Drug companies can ensure that their drugs receive favorable treatment by providing lucrative rebate spreads and other types of payments to the PBMs. Now, the terms of those deals are kept secret and staunchly protective. How do drug companies obtain the power for these secret deals? Using patents and other rights, companies amass volume positions, and then they create contract terms that will hobble generics when the generics finally do get to market. To do this, drug companies have become masters at repeatedly extending their protections. In fact, I have seen in my own research that drug companies are largely recycling and repurposing drugs these days rather than inventing new ones. So more than 3/4 of the drugs associated with new patents are not new drugs coming on the market. They are existing ones. Thus, instead of innovation, we are seeing secondary patents piled onto old drugs over and over again. When a company makes a secondary change to a drug, such as adjusting the drug's dosage, the R&D investment is often far less than is required for the drug's initial development. And in addition, the change may not mean much from a therapeutic standpoint. So we may be lavishing rewards without getting the innovation that we desperately need. Now, deciding what a drug should cost is tricky. For example, the value of giving my child a polio vaccine may be $1 million per dose because it would be worth that to avoid polio for my child. However, our healthcare system would collapse if we paid $1 million for every vaccination. If value is open-ended and has no sense of total upper boundaries, we could value ourselves into budget oblivion. Tax provisions also feed the patent and rebate games. Drug companies can donate their inventory, earning special enhanced value charitable deductions. In fact, such programs represent 10 of the largest 15 charitable foundations in the United States as of 2014. That's a large chunk of our deductions. Tax-deductible donations to patent advocacy groups also help push for policies that increase drug prices. Advertising to consumers, which is supported by the business tax deduction, also drives patients into higher-priced drugs. Advertising instructs patients, tell your doctor to make sure the prescription says no generic substitution. With so many citizens upset and often scared about the cost of their medicines, the time is ripe for change. It will require a partnership between Congress and regulatory agencies, and it will require changes both large and small. So with this in mind, I respectfully suggest policymakers consider the following changes to improve our nation's pharmaceutical markets. First, close the tax loopholes that allow drug companies to essentially deduct the cost of lobbying and other strategic behaviors. Second, to minimize the ability of brand-name drug companies to keep refreshing protection, implement a one-and-done principle in which a drug would receive only one period of exclusivity. The choice of one could be left entirely in the hands of the pharma company, perhaps one of their many patents, their orphan drug designation, their data exclusivity, and they can make the election at the time of the FDA approval. Third, transparency is critical. Markets like gardens grow best in the sun, and they wither without information. We should not put shackles around two of our greatest powers, an open and free market and an informed citizenry. And finally, the government funds an extraordinary amount of scientific research. The NIH, through the addition of key provisions in grants, could improve consumer access and to things developed with that research.
Thank you.
I agree, sir. Thank you very much.
Thank you very much for your testimony. Dr. Amit Sarpatwawi, close, is a physician and an attorney. He is an instructor in medicine and the assistant director of the program on regulation, therapeutics, and the law at Harvard Medical School. He's focused on prescription drug development, approval, and process, and related public health outcomes. Doctor, thank you for coming down to be with us today.
Thank you for the opportunity to testify. Chairman Doggett, Ranking Member Nunes, and members of the committee, my name is Amit Sarpatwawi. I am an epidemiologist and lawyer in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital in Boston, and an instructor in medicine at Harvard Medical School, where I help lead the program on regulation, therapeutics, and law. I will focus my introductory remarks on the scope and origins of the problem and the merits of some proposed solutions within the jurisdiction of the committee. Between 2011 and 2015, net spending on prescription drugs in Medicare Part B, Medicare Part D, and Medicaid increased 156%, 59%, and 55% respectively. Such growth has been driven by higher launch prices and markups on existing brand name drugs, which have greatly impacted patients. In an October 2018 national survey, 1/3 of respondents stated that they skipped a prescription fill in the past year due to cost. The pharmaceutical industry has attempted to deflect responsibility for these developments, casting blame on PBMs for allegedly not passing on rebates to payers or patients. However, drug manufacturers have vigorously fought attempts to shed light on net prices while reaping record profits. At the same time, the pharmaceutical industry has argued that high prices are necessary for innovation. Yet among the largest drug manufacturers, the average proportion of revenues that go to research and development is less than 20%, about half the proportion that goes to marketing and administration. Additionally, more than half of the most transformative drugs over the past 3 decades originated from public sector research institutions. The real reason we are seeing surging drug prices is because we allow pharmaceutical companies to charge whatever the market will bear, while also hindering payers' negotiating ability and permitting strategies that undercut competition. Several solutions have been proposed to address this problem. In February, the administration issued a proposed rule to remove the safe harbor for prescription drug rebates. The pharmaceutical industry has strongly championed the proposal. However, its projected impact is dependent on questionable assumptions. While it is true that PBMs have engaged in troubling business practices, they have also used rebates to negotiate lower drug prices in many cases. It is doubtful that absent other structural reforms, plan sponsors would be able to extract similar savings. Rather than seeking to eliminate PBMs, a better solution would be to set reasonable rules for their practices so that they can continue to contribute positive inputs into the system, such as promoting adherence and use of generics. Greater use of value-based pricing, arriving at drugs' prices based on rigorous, transparent, and replicable analysis of their benefits would also be helpful, providing cost savings while also incentivizing the pursuit of transformative innovation. In promoting value-based pricing, however, it is critical to distinguish approaches that claim its mantle but do not tie prices to its clinical benefit. For example, the pharmaceutical industry has championed outcomes-based contracting, yet such contracts often offer illusory savings. For example, a manufacturer can promise a refund in the event a patient does not respond to a drug, but price the drug such that the refund would be largely symbolic. Another promising reform would be to enhance the negotiating ability of public payers. Importantly, it is the ability of the Veterans Administration to set its own formulary and not cover drugs that do not offer patients added benefit that gives it greater leverage than Medicare in securing reasonable prices. The Medicare Negotiation and Competitive Licensing Act offers one possible way forward. It would instruct the Secretary of the Department of Health and Human Services to negotiate drug prices on behalf of Medicare Part D plans based in part on comparative clinical and cost effectiveness, so that a reasonable price can be reached that reflects the value of the product, with the possibility of competitive licensing in the event that a compromise cannot be reached for essential medicines. Americans have identified taking action to lower drug prices as one of the most important priorities for the new Congress. Their concern is understandable. We pay the highest prices in the world, which are often not connected to the value the drugs provide. Implementation of sensible reforms to increase the negotiating ability of payers and to promote greater competition in the marketplace can help make drugs more affordable without jeopardizing tomorrow's cures. Thank you. I look forward to answering your questions.
Thank you for your testimony. Amy Kapczynski is a professor of law at Yale and is co-director of the Global Health Justice Partnership there. She is one of the nation's leading experts on intellectual property law and access to medicines. Thank you for being here.
Chairman Doggett, Ranking Member Nunes, and members of the committee, my name is Amy Kapczynski. I'm a professor of law at Yale Law School, and I'm very honored to be here with you today. I will stress two things in my comments. First, the core of the high drug price problem is simple. Companies enjoy monopoly rights over drugs, and these are easily abused. Second, there are viable solutions that can both bring prices down and protect and even improve incentives to innovate. Today, drugs are regularly launched at prices in the hundreds of thousands of dollars. Older drugs are subject to repeated price hikes with no new innovation at all. The price of recombinant insulin, for example, has tripled in the last 10 years with no changes. In New Haven, Connecticut, where I live, 1 in 4 people with diabetes are now skipping doses or stretching or not filling prescriptions, risking serious health consequences and even death because they can't afford their medicines. At its core, the problem is actually quite simple. Originator drug companies enjoy monopoly rights in the form of patents and other kinds of market exclusivity. And we expect monopolies to do exactly what drug companies are doing. They set inefficiently high prices, and they increase prices wherever they can profit. The industry has also become expert in extending their monopolies, for example, through collusive pay-for-delay settlements and by creating patent thickets, obtaining patents that will eventually be invalidated as junk, but that can give them several more years of monopoly power. Fortunately, there are solutions. Congress can bring prices down and protect or even improve incentives to innovate. One important way is by giving the government the authority to negotiate fair prices. The Medicare Part D program, for example, pays 30% of all the retail prescriptions in the country, but is now barred from using its purchasing power to bring prices down. Congress should permit negotiation and at the same time set out criteria to ensure that companies are paid a fair price. What is a fair price? And it needs to reflect what we want, so we should pay well for what we value. So for example, we should pay more for more effective drugs, and we should take into account the costs and the risks associated with drug development. This will help ensure that companies receive a fair return and that the benefits of innovation are widely shared. You will hear pharmaceutical companies say that negotiation will undermine drug innovation. But industry spends twice on marketing, on average, what it spends on R&D, and it benefits greatly from a lot of government funding and innovation. Speaking more technically, the elasticity of innovation in the industry is relatively low, so the impact of price reductions on innovation would likely be small in comparison to the benefits. Indeed, government negotiation can benefit innovation. So how can it do that? If we ensure we pay more for drugs that provide more value to patients, companies will have more incentives to focus on developing those drugs. Today, bringing a 4th or 5th Me Too drug to market or upping your advertising budget may provide more attractive returns to companies than investing in breakthrough research. Government negotiation can change that dynamic. So what happens if companies refuse a fair price? There has to be a backstop to ensure that companies come to the table. There are many different ways to do this, but the most promising way is to address the monopoly problem. If the company won't take a fair price, the government can buy generic drugs instead, paying the patent-holding company a royalty. This approach is sometimes criticized by industry as breaking patents. This is misleading. Existing law already permits the federal government and its contractors to buy products without regard to patents as long as reasonable compensation is afforded. In fact, it has never been possible throughout the long history of the United States to stop the federal government from using a patent. There's a good reason, and that reason is to avoid the risk of what economists call holdup. Think about it like this. If a railroad is being designed, the last property holder on the line can demand far more than their land is worth. That's the monopoly holdup problem. And the government, therefore, has a right to take land subject to fair compensation. The government patent use power has a similar logic. It prevents holdup, and it gives fair compensation. Importantly, competitive licensing also gives companies a strong incentive to negotiate, so it's unlikely to be used often, precisely because it's an effective way to get companies to the table. Others have mentioned other important remedies as well, such as bills that would end REMS abuse and pay for delay settlements. These two are very important steps that can help bring prices down, and I urge you to consider them. I welcome your questions.
Thank you so much for being here. Dr. Holtz-Eakin, welcome back. A frequent presenter on a range of subjects to our committee. He is president of the American Action Forum and an economic policy expert. Thank you very much.
Chairman Doggett, Ranking Member Nunes, members of the committee, it's a privilege to be here today to discuss this important issue. Let me make 3 points, and then I look forward to the chance to answer your questions. The first point is that the conditions are ripe for upward pressure on drug prices. We have, in the United States, 60% of adults have a chronic condition, and 40% have 2 or more. Those are folks who will need medications. 86% of our healthcare spending is devoted to patients with chronic conditions, and that number is 98% in the Medicare program. So that there's going to be, as the population ages, rising demand for drugs. The supply side of the equation is pretty tight. It's very expensive to develop drugs. It costs an average about $2.9 billion and takes, on average, 15 years. There are a lot of misses in the drug development process. 1 in 1,000 formulas actually enters into a clinical trial, and only 8% of those ultimately receive FDA approval. So it's a system riddled with attempts at innovation that fail. That's the nature of science, and leads to the potential for tight supply. And anytime you have a chronic price problem, the problem really resides on the supply side in adequate supply and enhanced competition. And so those are the places to look. Second main point that I wanted to make is that there are lots of different measures of price or cost. There are list prices by manufacturers, net prices by list prices net of the rebates provided by those manufacturers. There's the out-of-pocket costs faced by consumers, beneficiaries in the Part D program. Some people point toward total spending as the issue, or spending per capita, or the drug share in spending. And the reason to list all these is that if you look at the data, they tell different stories. Over the past 6 years, for example, list prices rose between 7 and 13.5% per year, while net prices rose between 1.9 and 4.7%, and out-of-pockets were flat at about $30 on average. So you get a very different picture. What I would recommend that the committee focus on is the 2 clear places where we see upward pressure at the moment, and that's in specialty drugs, largely oncology drugs, and in some sole-source generics where manufacturers have raised prices dramatically for no apparent economic reason. Those are good places to focus. And in thinking about the policy issues, I would urge the committee to think about looking at existing policies that might actually be causing some of these problems as a first step. For example, in my testimony, we mentioned the 340B program. 340B program was created to offset the unintended consequences of Medicaid best price, which made it impossible to donate drugs to very poor Americans. Unfortunately, the 340B program has strong incentives for consolidation of health markets, as some research we've done has indicated, and it's very poorly targeted. It's not obvious that those benefits are going to individuals who are in need of help affording their prescription drugs. That would be a good thing for the committee to focus on. It's also important to focus on places to enhance supply. Approvals at the FDA are, in fact, a crucial part of this, and I think in recent years, the FDA has done a much better job at approving generics and making sure there was second and third brand name drugs in a class to produce some competition. The Hep C drugs are the best example of that. but there's some additional places you could look. I'd echo the call to look closely at REMS abuse as a barrier to entry and make sure that that system's not being used to stop competition. More generically, I think competition policy in this industry is something that everyone ought to think hard about, making sure that we have adequate policing of competition. And then the last would be to sharpen the incentives in negotiating in the Part D program. The Part D program has been a tremendous success. It's our best functioning entitlement program, but over the years, some of the incentives for negotiation have been diminished. And in my testimony, I outlined a set of reforms that would put insurers and pharma liable for the costs in the catastrophic region. This would diminish the incentives for pharma to develop high-priced drugs, and it would increase the incentives for the insurers to negotiate strongly for those drugs. That would also slow the growth of the most expensive taxpayer exposure in Part D, which has been the reinsurance program. So I'm pleased that the committee is looking at these issues. I'm delighted for the chance to be here today, and I look forward to answering your questions.
Thank you, Mike. Frederick Isasi is the Executive Director of Families USA, one of the leading national voices on healthcare generally, representing healthcare consumers and working to assure the best care is accessible and affordable to all. Thank you for being here.
Thank you very much, Chairman Doggett, Ranking Member Nunes, and members of the committee. Thank you for the opportunity to speak with you today. As you mentioned, I'm the Executive Director at Families USA. We are a nonpartisan nonprofit that has been working for nearly 40 years and has served as one of the leading national voices for healthcare consumers here in D.C., but also in all the states around the country. And thank you for holding this hearing. We are meeting at an extraordinary time for our nation's families. Despite the progress we've made to reduce the number of uninsured, families across the nation struggle with healthcare costs, which continue to rise much faster than their paychecks. Did you realize that almost half of Americans, 44%, report not going to see their doctors when they need to because they can't afford it? And then about a third report not taking prescription drugs because they can't afford them. Of these, more than 2/3 are choosing either to cut their pills in half or skip dosages. Terrible gambles. Think about the life that these Americans are living. Year after year, decade after decade, this problem of healthcare costs, and in particular prescription drug costs, is only growing more acute. In last fall's congressional elections, the American people sent a strong signal to all of you. An astounding 82% of Republicans and 90% of Democrats said taking action to lower prescription drugs should be a top priority for this Congress. This is a bipartisan problem, and it needs a bipartisan solution. And despite all of the complex legal and economic discussions you've just heard, and we'll engage in now, this is a very, very simple problem. Congress created a system that provides a government-granted exclusivity to drug makers. Over time, the focus of the industry has shifted from creating innovative drugs that can save lives to doubling down on high-powered lawyers to help them find loopholes, sue competitors, and generally abuse the spirit in which federal prescription drug laws were written. It is time for Congress to re-examine and rewrite patent exclusivity laws to stamp out these abuses. Short of this, other bold and important options are being considered, and we at Families USA are strong supporters of the Medicare negotiation bill authored by Chairman Doggett. The bill would allow Medicare to join other payers in negotiating prescription drugs. And we particularly like that it has a competitive licensing component, which is really about providing a strong incentive for manufacturers to show up and negotiate in good faith while protecting patient access. And of course, we're open to other proposals that will get manufacturers to show up and negotiate in good faith. I'd like to use the rest of my remarks, my opening remarks, to tell you a story about one Medicare beneficiary. It's a story about one person, but it really does tell the struggle of millions of others. Her name is Catherine, and she's from Wheeling, Illinois. She worked hard. She had a career as a secretary. And then in her late 50s, she developed a cough. It wasn't going away. How many of us have had a similar problem? Within 3 months of going to the doctor for the cough, however, she was told that she had a rare lung disorder and that without a lung transplant, she wouldn't live to see the end of the year. And then her condition worsened. Her doctors prepared her to die, and Catherine prepared herself to die. And then she got the call. A new lung had been found. She was going to live. This all happened about 5 years ago, this incredible gift and a new chance at life. But unfortunately, her experience has turned into something quite different. Catherine takes 36 pills every day, including an anti-rejection pill and pain medications. Each year, the cost of her medication puts her right into the Medicare Part D donut hole. Catherine has to ration her medications to make them last until her benefits at the beginning of each year. She spends an astounding $1,000 a month on her medications, which is exactly half of her income. Think about what this means. Catherine, after living through the experience of almost dying, receiving a lung transplant, fighting for her life, is left to spend half of her income to pay for these medications. You won't be surprised to know that Catherine has sold her home. She's moved in with her parents. Her mom is 86, and her dad just passed away at 89. She lives an extremely frugal life, but as long as her drug costs escalate year over year, she moves closer and closer to financial ruin and deep poverty. At the end of each year, she finds herself thousands of dollars short. She lives each day with the anxiety of wondering how she will find the money to pay for the drugs keeping her alive. That is the life that Catherine lives with amazing grace and courage, as do so many other Americans. Despite being one of the wealthiest countries in the world, despite spending 2 or 3 times more than the rest of the world on healthcare, this is the life we give to Catherine and so many Americans struggling with drug costs. Congress created this problem, and it is time for action. Thank you again for holding this hearing.
Thank you very much. I will defer my questions for a while and ask Mr. Thompson to begin.
Thank you, Mr. Chairman. Thank you for holding this hearing. Thank you to all the witnesses for being here. It's a very important issue for all of us. And every one of us on this dais have heard from our constituents about the ridiculous cost of prescription drugs, and many of those are Medicare folks. So to look at the Part D proposal is just, I think, a great place to start. And in the Congress, in this session, there are a number of proposals dealing with the issue of the high prices of pharmaceuticals, licensing to require negotiation, arbitration systems, incentives to encourage participation in arbitration, tax penalties for drug makers who don't negotiate, and relying on international reference prices to figure this out. So we all agree that we need to do something, but we need to make sure that the avenue that we pursue is the most transparent way, and it's done without cutting access to the needed drugs that our constituents rely on. And we don't want to stifle innovation. I think we probably all agree on that. And then in a district such as mine, and there's other folks on the dais from rural areas, but rural areas suffer, as do underserved areas, for a whole additional set of issues. And I know that PBMs imposing direct and indirect remuneration fees has really hurt my rural folks, and I suspect it's having the same impact in other underserved areas. So I'll start, Ms. Feldman, with you. What should we do about improving transparency in this particular area?
So you mentioned the rural areas and the independent pharmacists. In many cases, those independent pharmacists are the best friend that a patient can have in this process, and they are being mercilessly squeezed by the PBMs. The clawback system that you alluded to, the PBMs pull back payments after the pharmacist has prescribed the drug, and often the pharmacist can't make any money. If you're a big PBM and you own a big pharmacy, you're moving it from one pocket to the other. But if you're an independent pharmacist, it can drive you out of business. It's a terrible problem, particularly in rural America. I do think that the focus has to be in a couple of areas. One, transparency. We need to shine the light on the deals that are being made so that the market can work its magic. And second, we need to rein in all of the protections that companies are piling on one after another.
And Dr. Sarpatwari, Can you tell me what impact this rebate bundling and pay for delay is having, and what sort of redress should we figure out for that?
Sure thing, my pleasure. I'll start with the pay for delay. This is a particular issue in terms of new, very innovative biologics that are coming on the market. And there you've got a situation in which you have, as of February, I think it was something like 17 new biologics approved, but only 7 biosimilars approved, but only 7 on the market. The reason is that there were patent settlements in these cases. And the question is, these patent settlements benefit the parties, but they don't benefit the public. And what is essentially going on is we have, as a republic, said that we want to foster innovation, and you should have a certain period of exclusivity as a reward for your innovation, but these pay-for-delay settlements are extending that artificially. And there is legislation in Congress that would force those disclosure of those agreements to actually be public. And in those cases, that would enable better assessment of whether or not they are actually anti-competitive. And then in the case of rebates, I think we need to be careful in general about saying rebates are necessarily a bad thing. We have PBMs that have questionable business practices, but we also know that these PBMs have great purchasing power and are able to extract significant savings off of the price of drugs. What we need to do now is regulate their practices to ensure that those rebates actually are passed on to the payer and to the patient. So removing them from the system, I think, without some solution is not going to be helpful. They can actually play quite a good role in the system.
Thank you.
Thank you very much. Mr. Nunes.
Thank you, Mr. Chairman. Mr. Holtz-Eakin, I want to talk a little bit about the experience in the UK. You're probably familiar with the drugs Spinraza, a breakthrough treatment for spinal muscular atrophy, especially for children. It's one of the most expensive drugs in the world. You're familiar with it?
I am.
Okay. Recently, a group of doctors in the UK wrote an open letter about this crisis in The Guardian. Mr. Chairman, I'd like to submit this letter for the record.
Without objection.
Thank you, Mr. Chairman. The doctors write, as physicians, there is nothing more frustrating than knowing a medicine that can help your patients is out of reach. For parents, hope is taken away, causing unimaginable heartbreak. As the condition progresses, children are unable to regain lost function. Delay in treatment leads to the worst outcome, early death. Mr. Holtz-Eakin, if we change Part D to have a single formulary that considers the budgetary impact of providing coverage, such as some of the bills that are before this committee, could something like this happen to seniors in Medicare?
Yes. I think that's a real concern. Right now, the average senior has a choice of 27 different plans with different formularies. Moving to a single formulary runs the risk of having drugs excluded and the inability to access them.
Thank you, Mr. Holtz-Eakin. And under the compulsory licensing provision in the Medicare for All plan, what would happen if the federal government said it would pay for a cure, but a price the manufacturer felt was inadequate as defined in the bill? Does the manufacturer have any recourse?
No, not really, and I'm deeply concerned at the possibility of the compulsory licensing provisions. They undercut the basic innovation that has been the hallmark of American medical science, and they're inconsistent with our approaches elsewhere, where we, in trade negotiations, work very hard to provide protection for intellectual property, and then this would reverse that at home.
So what's happening in the UK? So it's just nobody's able to get the drug now, unless you pay for it privately?
It's a problem of access, yes. And it's not unique to that drug or to the United Kingdom. I think most members are familiar with the administration's Part B international price index proposal. One of the things that hasn't been highlighted in that proposal is that of the 27 drugs they looked at, only 11 are available in every country. Other people in other countries do not have access to the most recent therapies the way the U.S. Consumers do.
What are some of those drugs?
I don't know off the top of my head. I'd be happy to get the list.
It's 11 of, you said
11 of the 27 are available. 16 are not uniformly available.
Well, thank you, Mr. Holtz-Eakin. With that, Mr. Chairman, I yield back.
Thank you very much. Mr. Kine.
Thank you, Mr. Chairman, and thank you for teeing up such an important hearing. I mean, I think all of us, when we go home to our respective districts, hear these stories. It always comes up, whether it's in the grocery store, in my listening sessions, stories, as Mr. Isasi, you testified to about that woman and what she's going through with her life. So clearly, Houston, we've got a problem. And it would behoove, I think, the pharmaceutical industry to be stepping up with some constructive ideas on how they can play an active role and be helpful in making sure that all of our patients have access to affordable yet quality, effective drugs in their lives. And I think that's the goal. But I think all of us here on the dais, too, would agree that we're dealing with an industry that does take considerable risk. I think, Ms. Kopczynski, there are certainly nuggets of truth to what Dr. Holtz-Eakin testified to, that they invest money, they take the risk, there's a lot of failures, they are entitled to a decent return on investment on the drugs that they do hit on, and yet trying to strike that right balance, I think, is really the challenge that this committee has to wrestle. We don't want to stifle the innovation, but we also don't want to see excessive profit-taking, too, where it's not necessary. Is there any further guidance that you can provide us on how we can strike that right balance between encouraging the risk and the R&D that needs to go into it and the failures versus the high prices that our constituents are facing?
I think the most important thing is to specify, for example, in Part D negotiating authority, that you want to pay well for drugs that perform well, right? That you want to provide a good return on investment for companies, and that you want companies to be incentivized to provide drugs that really provide value to the American public, right? And part of what is so beneficial about that is, as others have mentioned, right now the system that we have encourages pharma to tweak old drugs and to do a lot of innovation that doesn't actually provide a lot of value to patients. And so what we want is a system that provides more value when companies provide more value.
Where are we on that? I mean, obviously, under the Affordable Care Act, we're trying to drive to value, to quality, the outcomes, and pay accordingly. How are we doing on that front when it comes to the drugs, the prescription drugs that patients are using? Are we developing good quality measures to know what are valuable and effective drugs and which ones aren't?
Well, I think part of the problem, for example, under Medicare Part D, is that we don't have a negotiating authority that can really look consistently at that problem across drugs. And so, to some degree, the PBMs are thinking about those issues, but not in a systematic way, in a way that I think really is what we need.
Yeah. Dr. Holtz-Eakin, welcome back. I mean, you've made so many appearances before our committee right now. You're probably entitled to a free coffee mug or something, but welcome back. Well, let me ask you something, because the Government Accountability Office just conducted a study back in 2017 in which they found, and I quote, between 2013 and 2017, the 5 largest U.S.-based drug companies spent 70% more on marketing and administrative costs than on R&D. Furthermore, between 2006 and 2015, the 25 largest pharmaceutical companies experienced average sale revenues increased by $241 billion, while only increasing their R&D budget by roughly $7 billion. Is there any reason to dispute these figures?
Not that I know of, no.
Ms. Kopczynski, back to you again. Is that a problem, that there's so much going into marketing and advertising and, versus R&D?
I think it's very clearly a sign of a problem, right? What we want is companies focusing their energy on real breakthrough innovations. And the system that we have now isn't really adequately encouraging that, and I think that's something that can really be addressed as part of this process.
Yeah. Ms. Spellman, let me ask you, because you mentioned in your testimony the problem with the extension of patent protection. But do we also need to be looking at the secondary patent system as far as things that need to be cleaned up and corrected, so it's not so easy for these patents to be extended unjustifiably or unnecessarily?
Absolutely. We want innovation. We want drug companies to go back to the bench, and we want to give them a good reward when they invent something. That's what we're trying to drive in this system. The secondary patents we have now are absolutely distorting the incentives, and they're distorting the innovation we're getting.
Mrs. Sassi, let me quickly ask you. I'm astounded by talking to doctors who claim that their patients walk into their office demanding a brand name drug because of a commercial they just saw on TV. I wouldn't feel confident doing that, because what do I know about what drugs I need in that? But yet it seems to be a powerful influence in how drugs are being prescribed. Would you agree that there's a problem as far as patients driving the demand for these drugs, especially the brand name and the cost that they're paying?
Absolutely, and what we know is the U.S. is one of the few countries that allows that kind of direct-to-consumer advertising for this very reason. What we should let is medical science determine what's the right drug for that patient. And it's a really serious problem that, that patients are being advertised to, and also they don't understand the cost associated with the drug. And so one proposal that the administration has made is to force manufacturers to actually put that price in the advertisement. We support that. It's just one small step in the right direction.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Kine. Mr. Buchanan?
Thank you, Mr. Chairman. Thank you. This very important hearing. I want to thank all of our witnesses as well. As someone that's been in business 30 years, one thing I understand is free markets and competition drives down lower prices. I look at generic drugs. I was looking through there. As we had more competition, we had lower prices. It's very simple to me in terms of that. This is more complex as an industry. But as you give more transparency, increase the pressure for competition, less monopolies, that's where I think we need to go. I'll also just add, I do a lot of town halls. I've done maybe 80 of them over the years. And one person stood up on a little different aspect of healthcare, but mentioned to me that they had lost their business and their insurance, and his wife had a bad back. She needed an MRI. They really couldn't afford it. Asked the doctor how much. He said $2,200. He said, "Doc, I don't have insurance. Is there any way I can get a better price?" This is what he's telling me is his story. He said, "If you do it for cash, I can do it for $1,800. Then he says, "Well, I'll call you back and check with my wife. I'm sure we're going to do it." So he said on the way home, he thought, well, he just dropped the prices 20%. I'm going to dig around and just make a few phone calls. It might be worth it. And he got it done for $400. So my point is we need more transparency. We need more competition. So Dr. Holt-Eaton, let me ask you, how do we create this idea of less monopolies in a sense, not that they all are, because in the generics it seems like there's an area that it's an opportunity to do more in that space, but how do we increase the competition in the marketplace? Because without that, it's going to go the other way at some point.
Well, I agree, and you know, that was the essence of my written remarks, was that we have to focus on enhanced supply and competition. As I noted, there are really two places where we've seen sharp increases in drug prices, and one is in these sole source generics, where companies buy a drug and suddenly raise the price by 1,000%. That strikes me as a place to focus, where that's not the kind of competition we want. We want better performance out of something that's not even on patent. And then the other area, which is the toughest, is this issue of on-patent specialty drugs, where we've seen the largest increases recently. And there, certainly, having the FDA approve as many drugs as quickly as possible. As I mentioned, the Hep C drug, Sovaldi, came in, a lot of furor about that. Once the competitors arrived, the prices came down, that there's no substitute for more competition in that case. And then the other is to compete on the right grounds, and there's been a lot of discussion of competing on value. I want to point out that this is more complicated often than people appreciate. In the end, this is all about beneficiaries in Part D. It's about their lives, the therapies they need, and the way they best take those therapies. So what looks like a valueless change in the delivery system, a lot of the patient advocacy groups
Doctor,
want.
let me go on the compulsory licensing. I just wanted to get your thought, as you commented on there about the ideas to theft and intellectual properties. In your opinion, that's something you said, but I want to not spend a ton of time on that. You can comment on it. But I wanted to talk about the idea of reasonable compensation. How do you get, if we're going to have the government involved in reasonable compensation, what is that? And then just my mind, the sense of litigation or negotiation could take years maybe to come up with a number that makes some sense. What's your thoughts?
In most settings, reasonable compensation is an arm's length transaction on a market price, and this is a situation where that doesn't exist. So I think you're going to end up with a very complicated, probably involve years of negotiation and or litigation to come up with that number.
And then let me also add, I have probably more seniors. I think I'm in the top 4 or 5 as anybody in the country. I'm in Sarasota, Florida, that region. Obviously, drugs and things are important. When I do town halls, one of the big things that always comes up, just your thoughts on it, is the idea, why doesn't the government negotiate ideally and have a little bit of a heavier hand in terms of pricing? The fact when you look at what we're spending in healthcare in general and you add it all up, it's probably close to $1 trillion in terms of Medicare and Medicaid and all the other things. What would you say to the seniors in Florida?
From the time the Medicare Modernization Act passed, when I was CBO director, to the present, this comes up again and again, and the same facts remain, which is that to get a better price, you need two things. You need to be able to bring volume, have beneficiaries, and you need to have a formulary so that you can give preferred treatment to the drug you're negotiating with. The Secretary of HHS has lots of beneficiaries, but no formulary. And I think it would be a remarkable step in the United States to exclude access to drugs by creating a single national formulary. And I don't think we're prepared to go there.
Thank you, and I yield back.
Thank you. Mr. Higgins.
Thank you, Mr. Chairman, and thank you for holding this important hearing on this critical issue and for your leadership throughout to focus on the leverage that the federal government has to negotiate down the cost of health care and up the quality, including as it relates to prescription drugs. My colleague Ron Kine focused in on the issue of industry advertising, the pharmaceutical industry. They spent about $6 billion doing that. It's about a 10% increase each year. And if you watch, pharmaceutical ads on television, they don't target consumers based on science. They target consumers based on emotion. In most of the ads that you see, the people are typically good looking, they're happy, and it always happens to be sunny. And that is an emotional appeal directly to consumers, bypassing the medical professionals that ought to be making these decisions. The United States is one of only 2 countries that allows for direct-to-consumer pharmaceutical advertising. The federal government is the largest purchaser of health care. It's the fastest growing expense of health care is the cost of prescription drugs. I have one thought and 2 questions for each of you. If you have a $1 trillion industry, the drug costs under Medicare are increasing between 11 and 14% a year. But given the number of Medicare beneficiaries that have the pharmaceutical benefit, the drug benefit, Medicare Part D, it's a lot of money, but it's a lot of leverage. And I think that the federal government consistently fails to use the market leverage of Medicare to drive down the costs of pharmaceuticals. We've been talking about this issue for 20 years, and drug prices are at a 20-year high today. So I have 2 questions. The first is the pharmaceutical drug industry, are they involved in a conspiracy to fix drug prices in the United States? And if we were to use the market leverage that we have under Medicare, by what percentage do you believe that we could reduce the cost of drugs? I also want to say that the idea of a conspiracy, a price-fixing conspiracy, is not mine. According to Humana, a conspiracy led by an unprecedented increase of 2,400% for drugs, 1,000% and 600%. 47 of the attorneys generals in different states have joined this lawsuit, alleging a conspiracy. So each one of you, if you would respond about the conspiracy, yes or no, and by what percentage do you believe, using that leverage, we can cut drug prices in America? Ms. Feldman.
Yes, sir. The name of the game in bargaining is bargaining power.
Right.
The bigger buyer you are, the more power and the more you can drive that bargain. It's worked very well for the government, for the Veterans Administration. It's worked better in Medicaid than in Medicare. Why shouldn't the government help with negotiating and still leave room for folks on their own to see if they can negotiate something better? That's
Yes,
what I
and-
would do if I had that power.
Okay.
You wanted a yes.
I want a yes, and what percentage do you believe that if we fully use that marketing power, we could reduce the cost of prescription drugs?
That I'm afraid I would have to think some more about. I don't have a crystal ball, but it
Doctor.
would be sufficient.
Doctor, you're up.
So to answer the question, should the government use its leverage in a better way? Yes, definitely. And I think that could have a meaningful effect on reducing drug spending. Again, a percentage I probably wouldn't be able to offer, but I think the real question is you could reduce it as much as you want, but how much can you reduce it without affecting meaningful innovation? And I think that you could reduce it substantially without affecting meaningful innovation. The second question as to conspiracy, I'm not going to go into the legal definition of
Professor.
conspiracy.
I would say with respect to the percent, I mean, one thing you might do is look at Europe, right? Europe, on average, many countries there pay half what we pay. You could also look at the VA, which pays substantially less. I think the figure there, something on the order of 40% for many drugs and so forth. So those might give you some indication if that's helpful.
It isn't. And I'll tell you, I expected more, to be truthful. You're all here, admonishing us to do more about this issue, and you have a certain degree of leverage yourselves as experts in the area. And I've read figures that say that, under the VA, there's a 40% discount by using the market leverage of some 30 million beneficiaries. Again, this whole idea of a conspiracy is not something that I've brought up. It's a lawsuit by Humana. It's joined by 47 attorneys generals. There is ample evidence to support this. And, we need the expertise of your industry to help us help the American people.
Thank you very much. I believe
I'll yield back.
Your time is up, and Mr. Smith.
Thank you, Mr. Chairman, and certainly thank you to our panel. I think the discussions we are having today are productive, and I hope that we can come up with some solutions. As mentioned before, this probably does need to be bipartisan in nature. I think that when you look at Medicare Part D, that competition between plans has been a key factor in its success. Ask a lot of seniors. Allowing premiums to stay relatively flat over the life of the program and for the Part D program to come in significantly under initial cost estimates. It's interesting that the term conspiracy has been brought up. I think that when you look at this entire industry, it's heavily regulated, and some of the providers in this industry have probably figured out how to leverage some policy against some other policy. And ultimately, though, we need to be very careful that the government doesn't just play into this and say that a single formulary is the answer. That's not what is consumer friendly. I don't think that's economically friendly. I don't think it's scientifically friendly, and certainly I don't think it encourages more innovation. When you look at the most innovative aspects of the industry, that drive, that competitive drive to come up with a better product is what will serve consumers far better than the heavy hand of the federal government coming in and thinking that, for example, a single formulary is the answer. So I hope that we can encourage competition, consumer choices along the way. I mean, I'm a consumer of an EpiPen, and quite honestly, before the prices spiked on the EpiPen, I was not really liking the price to begin with. And then it got worse. And I think, looking at that case and some others, that the longer a product has been around, the more expensive it has become. That, to me, is suspect, and let's look at that. So, Dr. Holtz-Eakin, what would you say causes such significant increases in price on drugs which have already recovered their costs of research and development, in your view?
It's simply a case of inadequate competition. I mean, if you've got something that's off patent, a sole source generic, that's just exploiting market power, pure and simple. And in some cases, it strikes me at least as an abuse of market power. I'm concerned about that. And,
so is there a
I don't
role
have
for
an easy
government?
solution there, but I think, monitoring the effective competition, and in every case, making sure there are no barriers to entry. We want to have adequate supply.
I mean, take the EpiPen, I mean, it's purchased in the hope of not needing it. So it's a little different type of a scenario where a lot of people need to buy it, whether they need to use it immediately or not.
Right.
So that, I mean, is there a role for government to encourage more competition? I mean, how can, or other panelists suggesting what might be done to encourage
Sure.
more competition?
So, sir, may I respond to that?
Hold on, let me,
Thank you.
let Dr. Holt speak.
You can't force people in. That's a step too far. But you want to make sure there are no barriers to entry, whether those are legal barriers like patents, but that's the brand world. What's really remarkable about these episodes is these are non-branded drugs that have one manufacturer, and you want to, always make sure that people are competing effectively. And there's a role for competition policy here, whether it's healthcare or any other area.
Okay, Ms. Feldman.
Thank you. Markets need to be fair, transparent, and efficient. Government can't be everywhere at once. You need the eyes of the market.
Do you think we should avoid a single formulary?
I think that we have had a lot of success in this country with allowing competition, both in terms of plans and in terms of drugs. I think that's a good approach for our country when we can. But we need transparency, because when the deals are hidden in the back room, the market's blind, competition can't reign.
Okay. I might, EpiPens have device patents on them, right? So that's not an example, actually, of competition. That's an example of the opposite, right? And I think these are some of the kinds of patents that Professor Feldman has been talking about, where you can kind of take old, what's in it is old. But companies find ways to kind of pile on patents and to then interrupt competition and then hike prices over time. And we've seen that time and time again, and it's obviously a problem. I think some of it goes back to thinking seriously, not just about competition where there aren't patents, but thinking about bringing leverage over circumstances where those are being abused.
Okay, thank you. My time has expired. Thank you, Mr. Chair.
Thank you, and Ms. Sewell.
Thank you, Chairman Doggett. Thanks for hosting today's hearing on the role of competition in playing and driving down drug costs. No one should die because they can't afford the best medicine and treatment available on the market. But today there are too many Americans whose ability to attain the medication they need to lead a productive life is determined by their socioeconomic status. I represent a constituency with some of the poorest health outcomes in America. My constituents feel that the impact of policies in Washington immediately affect their ability to purchase. And this is especially true when it comes to health outcomes. I'll tell you the story of an Alabama single woman who is an insulin-dependent diabetic. Like many diabetics, it has taken her years to find the right insulin mix. Years ago, when she was working as a home health nurse, she was on the insulin that her insurance would cover, but it would make her sick and cause her to have seizures. She now has a higher paying job, so she has chosen to take an intermediate acting insulin, even though it is much more expensive and her insurance will not cover it. She takes it because it doesn't make her sick and it has fewer side effects. This week she found out that insulin would cost her $1,200 a month before her deductibles reach. Fortunately, she was able to find a savings card from the manufacturer yesterday that trimmed down her cost to $700. It's still very, very expensive. No one should be subject to less mobility or poor side effects because the drugs they find or that they need is financially out of their reach. Many of my constituents are insulin-dependent diabetics, and diabetes is one of those expensive chronic conditions for patients. Insulin is just one of the costs that are associated with it. As representative of a constituency with high rates of chronic illness, I know full well that we have got to focus on prevention to truly bring down costs across the system. We must avoid any policy that would lead to increased hospitalization, decreased productivity, or poor outcomes. That is why I'm interested in some of the value-based proposals discussed here today, in which Medicare pays for the value of a drug based on outcomes. I wanted to ask you, Doctor, I think that you wrote in your testimony that the prices we pay are not connected to the value that the drugs provide. How do we how do we better pay for the value of drugs? And should we be willing to reward innovative treatments that improve the outcomes? I believe that was Dr. Swarpatweski. I'm sorry. I probably butchered your last name. But can you talk to us about the value of drugs and outcomes?
Sure. In principle, the idea at current, we do not do a good job of tying our prices or reimbursement to the value that the drugs provide. And so the notion of value-based payment is a good idea. The question is, how do you operate that in practice? And the concept is we need to make sure that at the end of the day, whatever scheme is being proposed, that actually ties to value. The problem I have personally with outcomes-based contracts is it doesn't necessarily imply that the initial list price, whatever that is reflective of the value of the product. So you can say and make very appealing that you will give a full refund in the case that you don't have this outcome. But if the initial price is not tied to value, those savings can be very illusory. And so we need to be careful about outcomes-based contracting for that point, but also for a second point, which is that the ability to track outcomes in our system and settings is logistically quite difficult, and what outcomes are actually meaningful. There's a lot of ways in which this system could potentially be gamed, and that's the only caution I would have in terms of approaching that question.
Well, thank you. While I don't have time to espouse on this, I also agree with several of my colleagues on reforms needed for the rebate system to increase uptake of generics and to increase transparency across the board. Mr. Chairman, I'd like to ask to submit for the record written responses from rural pharmacists in my district to questions I've asked about barriers to medication access and non-adherence. I appreciate the perspective that the academics here today have provided. I also value those of the pharmacists and practitioners in my area and would love to have those submitted for the record.
Thank you for that. Without objection, those will be made part of the record.
Thank you so much, and I yield back the balance of my time.
Mr. Marchant.
Thank you, Mr. Chairman Doggett. Of course, the thing that most of my constituents that I hear from about drug prices, their number one concern is the out-of-pocket cost. So if you get among a group of people that have similar hair color of mine, and you begin to talk to them, it really isn't about the theory of pricing and discovery and breakthroughs, et cetera, et cetera. The real thing they want to talk about is why is this drug $5 and why is this drug $35? And they really just want to talk about the out-of-pocket cost. And I've got a letter from one of my constituents that I'd like to read from. It's a grandmother because, you know, in many instances we find out that the high drug prices and costs to a family a lot of times involves more than just the family. It involves the grandparents. It involves the whole community in many instances. My grandson has type 1 diabetes and must have these drugs to live. The cost has gone up so much that it is keeping our family strapped financially. So much of diabetes supplies are not covered by many insurances, so when the drugs themselves increase by over 200%, it's outrageous. And this grandmother is saying, please, let's have a bipartisan examination of this problem and let's reach a conclusion. So this is really what most of our constituents are thinking about. I would like for each of you, if you wouldn't mind, taking a stab at what is the real relationship between out-of-pocket and the cost of the drug, and how that is really affecting, and what percentage of the people do you think that's the only exposure that they really have to drug prices?
Oh, thank you.
Ms. Feldman.
The out-of-pocket's what matters to patients in front of them. That's what they decide to put in their hand in their pocket. You asked about the relationship between the list and the out-of-pocket?
No, the relationship between the actual price of drugs and the pricing that's agreed on between all the benefit managers and the
Yes.
and how that's reflected at when the person goes to the pharmacy and picks the drug up.
Sure. So there are two issues. One is that we have strange bundled rebate deals, and these are distorting the market. So consumers are charged higher copays for buying the generic drug. That's entirely backwards. So you get very strange effects like that. But in terms of, again, that relationship, often the out-of-pocket cost for a lot of consumers is that very high price. It's not the deal that's struck for the PBM and the insurance company. 30% of consumers who have employer-sponsored plans have to pay 100% of that high list until they meet their deductible. A lot of people in Medicare and other types of plans have co-insurance. Co-insurance is a percentage based on that high price. And then, of course, I'm sure you have a lot of constituents who don't have prescription drug coverage or have no coverage at all. Those high prices hurt, and it hurts in the pocketbook.
Thank you. Doctor?
Sure. I would say that, yes, out-of-pocket costs are incredibly important, but at the same time, patients are also paying high premiums. And so the total cost to the system is also incredibly important. And here, I think I just want to introduce one concept, which is that manufacturers have done a great job in non-governmental programs in terms of trying to reduce out-of-pocket costs while marking up the actual total cost. And what that essentially is through mechanisms like patient copay support. What that is at the end of the day, I think a good line is that is a wolf in sheep's clothing that ultimately results in a higher cost to the entire healthcare system. So we need to be focused not only on out-of-pocket costs, but recognize that the systemic costs ultimately find their way back to the patient at the end of the day as well.
Thank you.
I agree that many patients are struggling with the out-of-pocket part of the story. It is also the case, though, that if the prices themselves are rising, even if out-of-pocket costs aren't, that the insurance premiums are going up, the taxpayer has a higher burden, and you're starting to get restrictions on drugs and things like that as companies are trying to kind of address the high costs. So there's many ways that these high costs actually end up affecting patients, even though the out-of-pocket is the one that's so salient when you go to get the drug at your pharmacist. I think we have to think about the problem together. If you only address the out-of-pocket costs, these other things are going to be an escalating problem, and we don't have a real solution.
I think there are two important options on the table right now for Part D. The first is the rebate safe harbor proposal by the administration, which a lot of uncertainty about that, but it will help those seniors who have the worst conditions and the biggest out-of-pocket costs by passing the rebate directly through to them. Other pieces of the system will have to change as well. The second is, in my testimony, we outlined a reform to Part D, which would give beneficiaries an absolute maximum catastrophic cap where they're not liable for costs forever, and eliminate the coverage gap. Those are things that are sensible and would improve the program.
Thank you.
Let me give you a really simple answer. Remember that at least 2/3 of the money flowing through the system is going to the manufacturer. So all of this discussion of PBMs and rebates, et cetera. So really, right now, the biggest impact on out-of-pocket cost is the price that these manufacturers are charging. And we know the prices are highest when they have no competition. And in diabetes medication and insulin, we've seen almost a 300% increase in 10 years, right? It is plain and simple, they don't have competition and they're abusing their power. So I think the number one way to drive down out-of-pocket costs is make sure that they're charging a reasonable price. I just want to say one other thing, which is there's been a lot of discussion about the success of Part D in managing price. And I just want to say that is a myth. And it's important to say this. Part D was designed to not have bargaining power. We have small regional plans that have very little negotiating power. And it is true that Part D has come in way under cost. It has come in way under cost because of generic substitution. That is true, and there's plenty, we're happy. Well, that is not wrong. There's terrific financial analysis. We're happy to share it with the committee. But if someone is telling you that the Part D costs are low because the plans that were designed to not be able to negotiate are doing a good job, they are not telling you the truth.
You're on the chairman's time right now.
Thank you very much, and Mr. Evans.
Thank you, Mr. Chairman.
A question that I would like to ask is, on this committee, at some point, we've been discussing the issue about trade and the exact impact. We have had the trade representative come before the full committee. And as you know, as genetic accounts for about 90% of the prescription drugs in the United States, but account for only 20% of drug costs. So the question I want to ask, and I want everyone to ask if you can anyone please discuss any obstacles to drug pricing reform in the current renegotiation of NAFTA, if you have any sense of that in terms of what's your thoughts and ideas relating to that agreement? Is there anything in it that we should be aware of? I'll start with Ms. Feldman and go down to...
The regional agreements, like the one that's being negotiated now, have sections that have very large protections for biologic drugs, higher than many other countries have right now, higher than for some of these, they've been higher than the ones we have in the United States. Those will end up harming consumers, particularly for biologics, which is the fastest growing segment of the market.
So one of the really key issues in the so-called new NAFTA, or NAFTA 2.0, is biologic drugs exclusivity. So there's a very substantial increase in the kind of protection. In fact, old NAFTA didn't require special protections for these drugs, and so it's sort of a new giveaway to the industry of a new protection for biologic drugs. One of the things that many have talked about in this chamber is maybe we need to lower some of the exclusivity for these biologic drugs, get the prices down, lower it down to 7 years. That would now be not possible for this chamber to do if the new NAFTA were passed, because it would require 10 years of exclusivity for biologic drugs. There's also provisions about secondary patents in there that could have some impact if Congress were to decide that they wanted the policy space to do something about that, and so there is a real concern about the new NAFTA.
And if I could just make one point, I think some argument there is that if somehow by increasing prices abroad that we will allow prices to fall here, there is no empirical evidence that suggests that would actually happen. So I think we need to keep that in the back of our minds when we talk about what reforms we want to pursue.
When NAFTA was passed, there was not a market for biologics, and they didn't exist. So as with digital goods and other things that have been invented in the interim, trade agreements now attempt to provide comparable protections for sales across borders as are provided in the United States. There is a fair and active debate about the appropriate length of exclusivity and other protections, but what's going on in the USMCA is really just an attempt to bring it up to modern standards.
What I would say is that there's a lot of concern about biologics, and one of the things that this committee may not have a lot of visibility into is on the state level right now, the pharmaceutical industry has traveled around this country and changed state laws to make it very difficult for doctors to actually prescribe biologics, generic biologics, once they come to market. So there's been a real concerted effort both on the international trade side and domestically to make sure that the public can never really benefit from these generic biologics when they come to market.
I want to follow up on something that my colleague from Alabama was raising to Ms. Feldman about insulin, which is the issue where I talk about the disparities really in terms of what happens for people. So can you speak very specifically, because I just saying my colleague, that seems like a very simple issue we should be able to do something about, but I don't understand why it's so difficult. So you want to speak on that issue?
So insulin drugs are a classic case of companies piling on protections. I've studied all of the top insulin drugs, and each of them managed to extend their protection by 20 years at least. All of them piled on dozens of protections, some of them as many as 55. That's what has driven the problem here. And it's a perfect example of what we need to address.
Thank you, Mr. Chairman. You're back to balance.
Thank you, Mr. Evans. Mr. Holding?
Thank you, Mr. Chairman. When I talk to constituents who participate in Part D, they all seem delighted. This is one of the few areas where healthcare policy gets complemented. So I was taken aback somewhat by Mr. Isaiah's comments, and so I'd like to call upon Dr. Holtz-Eakin to give his response.
I disagree with his characterization of the Part D program. It did come in about 30% below the projections that I made as CBO director at the time. It was not because we didn't anticipate the entry of generics. We certainly did. We knew which drugs were going to go off patent. We had a long list of those. We had information about the drug pipelines of the pharma manufacturers at the time. So we had a very good look at the first decade in the drug market, and all of those developments were anticipated. We underestimated the capacity of the combined prescription drug plans and PBMs to strike deals with the manufacturers. And the power of the negotiation proved stronger than anticipated, and it came in cheaper. I believe that's a big policy success.
Good. I'm going to follow up on Mr. Smith's line of questioning regarding EpiPens. I know a fine young man at home who's about 8 years old, strapping young man, very healthy, and when he was about 2, his 10-year-old sister gave him a kiss on the cheek, and his cheek swelled up to be the size of a softball. And it turned out that his sister had just eaten a peanut butter sandwich, and that caused an allergic reaction. So this young fellow now travels around with EpiPens wherever he goes, and EpiPens have gotten really expensive since Mylan acquired the EpiPen from Merck. 2007, they were $94, and by 2016, they were $609. I think the out-of-pocket cost for this young fellow at home is about $150 for a 2-pack, and he's going to have those for the rest of his life. And when Dr. Holtz-Eakin, you responded to Mr. Smith, said, you know, this is an example of market power. Mylan, is an actor here with market power, and they can command the price that they want to command. They introduced a generic version, which was somewhat less expensive, but still they have the market power. So when you come into an actor like Mylan, what do you do? I mean, is there a market-based solution to the instance of Mylan's kind of predatory behavior?
So I'm not an expert in this area, but given my understanding of what's going on, the delivery system is what is under patent. This was mentioned. That's exactly right. There are competitors, right? The drug itself is a generic, and there are competitors that have not managed to affect Mylan's ability to increase prices. But there are some competitors on the market. It doesn't look like we have effective competition. That seems to be something worth looking at without making a blanket assertion about the right solution to this. It's an important situation where you have a generic drug and the inability to get effective competition among the providers of it.
Right. The leaps and bounds in technology that are going on, innovation with our drug companies is pretty astounding. And I have hopes that someday they will invent the perfect medication so I don't have to diet and exercise anymore, and perhaps I can ingest that new medication via cigar, and it will all be just really a wonderful outcome. So I want to make sure they always have the ability, the resources to do those innovations. But we are hearing from constituents and family members and everyone that we talk to that we need to address drug pricing. So I look forward to working with my colleagues, my friends, on this side of the aisle and the other side of the aisle, try to find some solutions, hopefully market-based, that will address these concerns. So thank you. Now
Thank you very much, Ms. Chu.
Yeah, I'd like to thank Chair Doggett for calling this important hearing today and for all the work he's doing on lowering the cost of drugs for American patients today. And I'd like to follow up on the testimony so far by saying, well, it's pretty safe to say that the pharmaceutical drug industry is doing quite well and that the steady trend of price increases is not due to the industry's lack of revenue. In fact, there are record profits, high bonuses and salaries for CEOs, and many stock buybacks. And as my colleague Mr. Higgins and Mr. Kine pointed out, drug companies are spending 70% more on ads than on R&D, and that these ads are driving patient behavior. But Ms. Feldman, isn't it also true that drug companies receive tax benefits for these direct-to-consumer ads?
Drug companies do get a business tax deduction for the expenditures on direct-to-consumer ads. They get a significant benefit for these. Ads can drive patients to buying things that they don't realize they can get much cheaper, like drugs that are, a drug like Trexamet that's an $800 combination of something you can buy for about $15.
And are there other incentives in the tax code that drug companies are exploiting? And if so, how can they be changed?
There are incredibly generous provisions related to donating your inventory. As I mentioned before, 10 out of the 15 largest charitable foundations as of 2014 were drug companies doing this. They also can take deductions for donations to patient advocacy programs, and those programs sometimes push for policies that push prices higher.
And Mr. Sarpatwari, I think we've made it clear that drug companies are getting a significant return on their investment. While we've heard a lot from drug companies about the risks that they take in research and development of new drugs, I'm wondering if American taxpayers take on any risk through the NIH, and if so, how?
Yes, so each year NIH spends about $30 billion on research, and as was mentioned by the chairman earlier, from 2010 to 2016, all of the new drugs that came to market had some basis in government funding. And so we take a look at the most transformative drugs over the past 30 years. More than half originate from public sector research institutes funded in part by the government. There is a considerable amount of risk that the government assumes, and we're not just talking about basic science research, we're talking about up to the development of the product itself. And while drug companies do an incredibly important job of conducting the pivotal trials that are necessary to bring a drug to market, the public itself is not benefiting from those investments that the government takes oftentimes. And there are proposals out there to reform that situation and make sure that American taxpayers aren't paying twice.
In fact, hasn't the U.S. poured over $900 billion in basic and applied research for the pharmaceutical industry since the 1930s?
That is correct.
Ms. Feldman, can you elaborate on what actions Congress can take to push back on patent abuse by drug companies, particularly as it relates to patents for NIH-funded discoveries? Do you think any of your proposals would be a barrier to additional innovation, as drug companies often claim?
Innovation is critical, and we can do it well if we have a market that is fair and efficient and transparent. So my strongest recommendations are keeping open pricing information, allowing one period of patent protection, not dozens, closing tax loopholes, ma'am, that you referred to, and using the power of government contracting through the NIH and others to control behavior.
In fact, isn't it true that the big companies are relying now on small companies to do the R&D? Can you explain what's going on there?
Yes, the innovation is not happening primarily in-house at the large companies. It's happening at the universities. It's happening in smaller companies. The large companies play an important role in getting this to market, but you have to look at the entire system.
And then do these large companies then buy the small companies?
I'm sorry, I couldn't hear the question.
Well, the small companies, it seems to me, take the risk at this point. And then they do the R&D, and then have there not been instances where the large companies then buy up the small companies after the small companies take all the risk?
Thank you. Yes, the reason that we justify large patent rewards is because of the risk that is involved in doing the research. If the large companies aren't doing that risk and taking that risk, and in fact, if no one's taking that risk because they're just tweaking the medicines that are out there, we aren't getting a very good deal here.
Thank you. I yield back.
Thank you very much. Gentleman from New York, Mr. Reed.
Well, thank you, Mr. Chairman. Thank you for hosting this and having this hearing, because I think there is a lot of bipartisan recognition that drug pricing in America right now is a problem. We've all heard from our constituents. We all have heard this issue as we've traveled around the country. And I will also tell you, as the father of a type 1 diabetic, I have seen the insulin issue myself firsthand. So I join with my colleagues in regards to trying to find a solution to this problem. And I associate myself with my colleague from Wisconsin when he's asking the pharmaceutical industry, the pharmacy benefit management companies, and others to come to the table in good faith, to be part of the solution to come up with a solution to this drug pricing issue. That being said, I am optimistic that even in this hearing today, at the core of the testimony and the core of the information that's being provided, that the market pressure, a free market system, is the tool that should be used to drive prices down. Even when we talk about negotiation between the government and the pharmaceutical company, as is being proposed by some of the members on this dais, the root core of that is market pressure. And I appreciate that. And I think that is where the solution lies, rather than taking over this industry or taking over this space with some type of government fiat. And because that is what I am concerned about most when I hear the testimony today. And I hear the proposal of negotiation by the federal government so long as the seller agrees with the price. If the seller doesn't agree with the price, well, then what we're going to do is take your property. That is an impossible free market system to use market pressure in the most effective way, in my humble opinion. Because essentially what you're saying is, we are going to give you the price because we are those in the government that know best, and this is a fair price to offer you. And if you say no, we're going to take your property. No other free market system where you have a seller has the authority or the power to do that. And my concern, if we do this, and maybe Dr. Holtz-Eakin, you can comment on this, is if we do this, if we take that property away and say, if you don't accept our price, we're going to do this, who's going to stay in the game to innovate? And aren't you creating a system where if I'm a potential entrepreneur, I would say, okay, you guys go negotiate with the federal government, and then when they take your property, then I will start my business after you have already put in all your costs, all of your research development, all your infrastructure of making that investment and putting your capital at risk and your life at risk. So now I'm the new startup just sitting on the sidelines. Just sitting on the sidelines and maybe manipulating and taking advantage of that situation. So we got to think this all the way through. So, Dr. Holtz-Eakin, am I missing something in that analysis of the proposal?
No, I don't think so. It's a little ironic. After the fall of the Soviet Union, many countries tried to establish market systems, and one of the first steps that was necessary was to establish private property rights. If you don't have those, you can't have a market system.
You can't have a market system.
Stripping property rights isn't the solution.
And using the market pressure, and this is where I really want to maybe for a minute here, out-of-pocket cost. Where is that in the existing market system as a calculation of pressure to drive that cost down? Because I don't see it. That's the fundamental problem, I think. When you're negotiating now in the existing marketplace, no one's taken into consideration that out-of-pocket cost. It's between the list price and the net price, between the pharmaceutical, the PBMs, and the providers. Where is the patient? And also, when my colleague from Texas talked about going to the pharmacy, no one talked about the doctor in this equation. The doctor already wrote the script. By the time I get to the pharmacy, I don't have any negotiation because I already know what I'm buying. So how do we bring the doctor and the patients into this marketplace to drive the market pressure to get these out-of-pocket pressures going down, or costs going down?
Well, certainly of the things that are on the table right now, I mentioned the reforms to Part D that are in my testimony. I think those make a lot of sense and would. How
do we get the doctor involved in this transaction? Who's writing the script?
So the there's ought to be, in the magical world of electronic medical records, the capacity to look and see what the current price of a pharmaceutical is at the time the prescription is written.
And that gets into the transparency. And I think
Yeah.
transparency is common ground here that we could explore. And with that, I yield back.
Thank the gentleman. Mr. Blumenauer.
Thank you, Mr. Chairman. I'm just pondering my friend from New York. I'm trying to envision this as a pure free market, because everything I heard from most of our witnesses and what I know about this is that this is the furthest you can get from a free market. I mean, first and foremost, we have people here who have an exclusive right to this product. They can't legally have competition. It's this monopoly that the federal government has decided there's not going to be a free market. The federal government pays for an extraordinary amount of the research that is used by this product. The federal government pays the bill. So on what planet is this a free market system? And I think your constituents and my constituents would not confuse this with the free market by any stretch of the imagination. To the best of my knowledge, and I'm going to have two questions and the panel can, there is no free market anywhere in the world for pharmaceuticals. None. What we have is the highest prices in the world because of our odd, complex, hybrid system of modified protections. We have all these payers because it's hopelessly complex. There is no free market on this, and if I have time left, I'd be happy to yield to you. But, I mean, we've been spending a lot of time, some of us dealing with health care, on this committee with the Affordable Care Act, the refinement, the efforts to blow it up. But I have seen nothing that indicates there is a free market that's operating. What happens in the rest of the world is that they piggyback on us, they use some of the research, they pay a fraction of what Americans pay. So I just reject that premise, Tom. But my question, and I just go down the row to our witnesses, time permitting, I've hopelessly squandered half of it. My two questions, quickly, is there any place in the world that has a free market for pharmaceuticals? And I think that could be a yes or no, and if there's something. But I'd start with you, Ms. Feldman. What is it that prevents in our system somebody taking insulin, which was developed over a century ago, and just go back to the fundamental? No bells and whistles, no special flavoring, no prize in the Cracker Jack, but just bare insulin that kept people alive. What's preventing somebody from entering that market now if we have a free market?
A simple and quick answer. You can make drugs, but you can't get them to the patients if the health plans and the PBMs won't cover them on the formularies. There are charitable foundations right now who are trying to do exactly what you've said, but it's very difficult for them to get the plans to pick them up because of the deals that the drug companies have made.
Is there a free market for pharmaceuticals anywhere in the world?
In theory, we would have a free market when these protections expire. I am still waiting for that.
I'm sorry.
No, we don't have a free market anywhere in the world for pharmaceuticals. And just to complement Professor Feldman's point, I think another critical issue in terms of getting other manufacturers of insulin to market is the notion that we've talked about $6 billion in direct-to-consumer advertisement. We haven't talked about $30 billion in marketing to physicians. And that is an extraordinarily large market that is preventing the prescribing of cost-effective medications.
I have 30 seconds left. I'd like to turn to you, but I want to courtesy to my friend.
Yeah. Well, then let's be honest about the debate here today. If you're not recognizing that we could have a free market pressure system to contain these costs, then what you're offering is government-controlled takeover of the pharmaceutical industry in America. And that is a fair debate to have. If you want to rely on government control in this area, that is fine. But what I do believe is that we can have market pressure. We can have market pressure drive these costs down. And I yield back.
Reclaiming my time, poppycock. And I look forward under the
I appreciate the substance of the debate saying poppycock.
Under the leadership of the chair, I think we can dive into this to really ferret it out. Tom, to find out what you think is free market about this. And, you know, I'm happy to have that debate with your constituents and mine. But it's not taking over anything. We've already set the rules. We've given them a monopoly. We pay for it. We pay for the research. And I think we ought to be able to find something in between there to follow through on the proposals. Thank you, Mr.
Schneider.
Thank you. Again, I want to thank the chairman for hosting this hearing and the witnesses for joining us today, sharing your expertise with our subcommittee. I also want to say this is a vitally important issue for many of my constituents, including Catherine, Mr. Isasi. I believe everyone here on both sides of the aisle is committed to ensuring our patients have access to some of the truly amazing life-saving treatments on the market today. We may differ on how to get there, but we all share the same goal, and I hope we as a committee don't lose our focus on the patients as we continue our work. There are a lot of ways to address these issues, but whatever solution we reach, we have to make sure we are first and foremost best serving our patients that need these drugs. Today, I want to discuss the specific issue many of you briefly touched on, as have my colleagues, insulin. More than 30 Americans have diabetes, and from 2002 to 2013, the total cost of managing diabetes in the United States collectively increased almost 30%. According to the American Diabetes Association, care for those diagnosed with diabetes account for 1 in 4 healthcare dollars spent in the United States each year. That's an extraordinary amount of money for both public and private payers, but is only exacerbated by the fact that 1 in 4 diabetics admit to having rationed his or her insulin. Insulin is not new. The drug will be a century old in 2 years. But despite that, insulin spending has increased dramatically over the last decade. The annual cost of insulin for type 1 diabetics has doubled in the last 4 years, even though insulin use has remained relatively flat. Mr. Isasi, you told a number of moving stories about patients and the cost of their prescriptions, but I was hoping you could touch briefly on what effect the cost of insulin is having on diabetic patients, particularly those enrolled in Medicare.
Thank you very much. It would be my pleasure. As we've talked about, insulin's another good example of a part of the pharmaceutical market that has no real competition, and they've used patents and new slight tweaks to continue to extend their ability to not have competition. Prices have increased, depending on which particular drug you're looking at, about 300% in 10 years. So a complete abuse of competition. And the discussion we had about Catherine, that wasn't a diabetic patient, but we have lots of patients around the country who are struggling with this. Let me tell you the story of Wendy from Georgia, from Champion, Georgia. She literally goes on her Facebook page and asks for donations so she can pay for insulin every day. Let me tell you about Alex Smith, which is a very famous story. Alex, 2 years ago, he was 26 on his parents' insurance. He got his insulin. He had type 1 diabetes like we've talked about. Alex came off his parents' insurance when he turned 26, and he stopped being able to pay for his insulin, and then he died. He tried to cut his pills in half, or he tried to cut his dosage in half, and then he passed away. Mallory from Wisconsin, she's also on insulin. She made the decision, she turns her insulin pump off because she is so scared of incurring more debt that she'd rather just take the risk, to quote her directly, of not waking up than having to go into more debt to pay for her insulin.
Thank you, and I appreciate those stories. And I think these stories and the issue is particularly timely because just this week, one company, Eli Lilly, announced they would be offering an authorized generic of its most popular insulin product at half the price. That may sound great on the surface, but I think there's a lot more that we can unpack. If I can ask Dr. Sarpatwari, can you discuss what the new offer would mean for patients, both insured and uninsured, and what it means for public and private payers? Will it make a dent in what government spends each year, and will help patients afford their insulin?
So I think we need to be worried about what an authorized generic actually means in terms of competition. On principle, like you said, it's good that we are having a price decrease, but when we look relative to what other countries are paying for their insulin, even this discount is a drop in the bucket. And so we need to ask ourselves, why can't we get to the prices that other countries are paying for their insulin? We also need to take a look at the role of authorized generics and how authorized generics can actually lead to enhanced profits for the companies, and whether or not that means how we can regulate better the intermediaries in the system. So I'll leave it at that.
Thank you, and I have just a few seconds left, but if I can turn to Dr. Holtz, you in your testimony talked about an example of how competition can lower the price of drugs. The example was treatment for hepatitis C.
Right.
But this seems to be if not unique, a very rare circumstance where we're seeing that competition. What can we do as a committee, as Congress, to try to create more opportunities for stories like that? Are there other examples you can point to?
Well, I think one of the most important things is the FDA and the processes that guide its approval decisions. You know, often it was say, we don't want a second drug. That's just a me too. We have something for that already. That turned out to be a mistake. You want the second drug. You want the third drug if possible, so that someone is always under pressure to keep their prices down.
All right. Thank you, and I went over. I appreciate that.
Thank you.
Time. I
Mr.
yield
Gomez?
Mr. Chairman, thank you so much, and thank you all for being here. It's I always like to hear about when people talk about market and market pressures and just what's causing prices to increase, and then at the same time, how it's going to solve all the problems. And one of my concerns is that when it comes to medicine, especially, it's not like buying a car, right? If you don't get insulin, you die, right? It's a certain type of insulin. You have that insulin. That's your choice. Few manufacturers, but you're going to pay a price, and it's going to be high. When you want to go and buy a car, well, the car, you don't have to buy the Lexus. You can buy the $800 used vehicle that barely runs, but it's going to get you from point A to point B. Very different. And I think that's what we tend to forget. I started listening to a lot of the testimony, and I was curious about the history of insulin after listening, and I looked it up. And this is something that's been going on, not just this debate about price gouging on insulin has been going on since it was invented, right, for the use of treating diabetes. There's an article, just for the record, that I found that basically said that 3 companies were sued in 1941 for price gouging regarding insulin. Did you guys know that? So just for the American people's sake, this is not something new. But what I think I'm concerned about is I don't want to be here another, 50, 75 years to have the same debate about price gouging over pharmaceutical drugs, right? That's not where we want to be. We want to really look at the solutions and really look at how do we fix the problem. So that's something I was thinking about. I think it was Ms. Feldman mentioned one period of exclusivity to deal with some of the issues. What would the opponents to this say?
So I call that one and done, one period of exclusivity, and then you're done. Pick anyone you want. I think the opponents would say that they want to be able to make changes and new improvements to drugs. And my answer would be that it doesn't cost very much to make most of those changes that are out there right now. And so you should be able to get your reward when you sell it. You don't need a government-granted 20 years or whatever it is of monopoly. What we need is a period of protection, and that's it. When it ends, it ends.
Since you're taking Dr. I can't see your name from here. Yes.
Holtaken?
Yes. What would your response to that concept be?
That doesn't strike me as a bad concept at all. The issue is what is really one, and what proponents of the current system would say is, well, this drug really is a new drug, and it deserves a period of exclusivity. It's not really like the old drug. We know that's not always true. So the question is going to be, how can you distinguish the one, which should get a period of exclusivity, from something which is not genuinely an innovation?
Okay, so I'm starting to see some agreement, which is rare, but I'm happy to hear that. How would we go about defining that period of exclusivity?
I think she should answer that. I have no idea.
So the proposal I have, let the drug company decide that. Let them. It can take very different amounts of times to get through approvals, to get your medication stable. So when you get your approval, you as the drug company, you decide. The strongest patent you have, that's the one you want to go with. The orphan drug exclusivity, that's the one you want. Some other protection you've gotten out there. Congress doesn't have to sweep away all the protections it's created. Just at the time of approval, tell the drug company, pick one.
No, thank you. And before my time runs out, I also just want to ask one question. Analysis shows that like the top 10 selling drugs in the U.S. from 2011 to 2015, as you all know, were increased anywhere from 54% to 125% in just 5 years. Drug list prices increase have outpaced general inflation, medical inflation, and overall wage growth for many years. What can we do that will stop these arbitrary and indiscriminate list price hikes to help patients afford their medications? This one's easy question.
In 10 seconds, so obviously government negotiating power can start to say we actually will only give you the value that your drug is worth and can't just keep hiking the price. I mean, there have also been some proposals about specific legislation to prevent price hikes, and Congress can consider that as well.
All right, thank you. I'm out of time, but I'll yield back to the chairman.
Thank you very much, Mr. Horsford.
Thank you, Mr. Chairman. This is an incredibly important hearing, and I continue to hear from my constituents in Nevada about the challenges that they face in obtaining life-saving medications and treatments due to prohibitive cost. And in my opinion, too much attention and focus is on the drug manufacturers, the PBMs, and the insurance companies, and too little attention is really on the patients. This should be a patient-centered policy, and whatever is in the best interest of the patient is ultimately what we should do. That's who I was elected by, that's who my colleagues was elected by, and with all due respect, you know, it's drug company monopolies and their rights should not trump patient rights to quality health care and the ability to afford life-saving medication. And it is personal because each of us has family members, constituents, ourselves who have been afflicted with serious disease that but for life-saving medications, we will not be alive. One person that I'd like to share their story is Jaden from Pahrump. He's one of my constituents who faces life-threatening choices when it comes to his medications. Jaden has diabetes, which has severely limited his mobility. This has impacted his ability to not only make a living, but also prevents him from performing everyday tasks. In fact, Jaden lost his job because he could not stand on concrete for 8 hours. Without his job, he has a limited income and cannot afford his insulin, which costs $250 a month. He often limits his insulin injections or simply goes without it when he does not have the money to pick them up. Ladies and gentlemen, this is a very dangerous decision that can result in long-term health complications or even death. Now, we've all stated that Jaden should not have to face this tough and inhumane choice, especially when we know that insulin prices were not always cost prohibitive. Now, in my home state of Nevada, I'm proud that our state legislature, under the leadership of Senator Ivana Kinsella last session, took steps to require increased drug price transparency. Our state law requires drug companies to disclose their opaque payment structure, including rebates, how much it costs to make the drug, and the funding they provide to assistance programs. I strongly believe that Nevadans deserve this information as they continue to pay more and more for prescription drugs in order to stay well. So, Ms. Feldman, you've done a lot of work on transparency in the drug market. What do you recommend Congress do to improve transparency in the drug market, and how do you think transparency helps patients who ultimately should be at the center of this debate?
So first, thank you, sir, for reminding us that this is about real people. I'm not familiar with the details of Nevada, but it sounds very much like what I would recommend on the national level. We need to bring transparency into pricing and end the secret deals and the extra protections. If we do that, the closer we will come to a free and fair market, and the better off we'll all be.
And based on the prior hearing that we've had on this topic, what is proprietary about disclosing cost around marketing and administration? Some drug manufacturers are claiming that's proprietary information. Do you agree? And if so, why is that proprietary? And if not, why should that information be part of the disclosure process?
So drug companies claim that information as trade secrets. As someone who's been in intellectual property law for decades, I find that a little puzzling. However, it is information that if you want to have approval of drugs, you ought to be willing to share, and information should be open in a market in any event. Now, some people have claimed that if you put information out there, you will get collusion. In my view, collusion happens when you have secrecy. You're less likely to get collusion if everybody's out there out in the open, and you can always deal with those problems.
Well, right now we have 3 companies that market insulin, and those costs have increased 197%. So if there's any questions around price fixing, I think we already know the culprit. Thank you.
Thank you, Mr. Kelly.
Thank you, Chairman. Thanks for holding this hearing today. In the hearings, promoting competition to lower drug prices. That's the title of the hearing. It's very important to lower drug prices for all Americans. I think we all agree on that, and there's probably not a single person in this room or sitting up here in the dais that either doesn't rely on some type of pharmaceutical or have family or friends to do that. But the compulsory licensing is the government theft of intellectual property. I firmly believe that. And I'm part of something called the Innovation Caucus. And I think the main driver, and I want to go with Dr. Holtz-Eakin on these things, the opinions on this. Listen, there's nothing that drives improved products more than competition. And in incentivizing people to do that, I don't want to see the government get into a situation where the government determines what the price should be. Based on what? Based on what? If you can, Doc, just address that a little bit, because a government-run system, I don't have any idea what that would ultimately have on prescription drugs. What would we look? Would we look like public utilities?
I don't really know exactly. There have been proposals. Well, let's do it this way. We know that in the bulk of the economy, value is revealed by people's spending decisions. They show their value by forking over their money for it. The more that can be relied upon, the more likely we are to have beneficiaries that are happy with the system. And so the difficulty comes when you move away from that. So, for example, if you decide to determine value by a group of clinicians, perhaps at the launch of a drug, with no particular information about what patients might care about in the use of that drug, then you've moved away from using the beneficiary who we care about to determine value. And I think that's troubling, because you then have to figure out who gets to pick the clinicians, and then you get into the politics of that, and pretty soon that system doesn't look like one that's getting closer to what people want. It's moving further away from it.
Yeah, I've just always thought that the model that we use in America, where we're actually incentivizing people to go out and develop new products, new services, whatever a consumer would decide what was in her or his best interest, and then they would flow to that type of a product. I'm really concerned with the idea that we think that somehow the federal government has the ability to do this. There's nowhere in history where this type of socialized economy has failed. Am I wrong on that, Doctor? I mean, you studied this. You know it better than anybody.
Yeah, I would not want to characterize the U.S. health sector as a perfectly free market. There's an enormous amount of government intervention. I think the key at the moment is to, where you have the opportunity, move toward better use of market forces, which have historically delivered better quality, lower prices across the globe. And that's the debate we should be having. Where can we do that? And And in the current setting, there are some things that I think would be beneficial in doing that, whether it's reform of the Part D benefit design, or if you look at the rebate rule, that would move away from having multiple prices. There'd be a price, one price negotiated between manufacturers and PBMs on behalf of prescription drug companies. That would be a step in the right direction, a lot more clarity, ability to compete on the right grounds.
Okay. And I want to go back to this compulsory licensing and this also called government theft in some areas. And this is a question for every one of the witnesses. So if we think that the government should seize the intellectual property of other high-priced products like iPhones, cars, laptops, somebody made reference to automobiles, what if the government were to decide what it is that you should drive, where it is that you should live, what it is that you should eat, where it is that you should go to church, or maybe you shouldn't even go to church anymore? I'm just getting to the point here. I'm watching the idea of a bigger government dictating to the population that it serves that, no, we know better than you. So I'm really concerned. So is more government control the answer to this, or less government control, and looking again at the benefits of free markets and where we could go and why people do try to innovate and change the course of the way things are going? I mean, I look at what's happened with pharmaceuticals. It's incredible what we've been able to do.
So, sir, I would return to something that I said earlier, which is government can't be everywhere. You need the market, you need the eyes of the market, and you need to let the market function in a fair and transparent and efficient manner. That's why I believe transparency is so important here. Okay. Right now, the markets are flying blind. We need to help them operate to the best extent they can.
Yeah. Doctor?
If I may.
Yes, ma'am.
You know, you can see that patents and these kinds of exclusivity are also government intervention, right? That's part of the point. And I want to say, it's striking to me to hear, you know, government patent use described as theft. I mean, Alex Azar then would be a thief, because when he was general counsel of HHS relied on government patent use to say, wait, we have an anthrax crisis. 9/11 had just happened. Cipro was an important drug, and the company Bayer was trying to gouge the government on the price. And Alex Azar is not a Soviet, you know, entity. He came in, he was part of the process that said, look, you can't hold us up at this moment. And he drove the price down, and he defended that. And he said, this isn't theft of property. This is using a law that exists, and we'll pay compensation, and that's the right way to do it.
Thank you. Your time has expired.
Oh, okay, thank you, Chairman.
And Mr. Rice.
I am very wary of increased government control. I certainly believe in the saying that you never know how expensive something can be until the government gives it to you for free. You said, Mr. Asasi, that the cost of insulin increased 300% in 10 years. And I think you said that the average cost of drugs from 2011 to 2017 went up 60%. But the government took control of the health insurance market in 2014. And the idea was to increase competition and drive down costs. Well, the exact opposite happened. I mean, we have, you know, one health insurance provider in South Carolina now. We had 5 or 6 or 10 before. And the cost of health insurance went up 230% in 4 years. 230%. It'll easily outpace your 300% growth in 10 years in the prescription drug market. So I agree that this is not a purely free market. But the answer to high drug prices is to move more toward a free market and not toward more government control, because time and time again, the exact opposite happens. You say we're going to drive down prices, and in fact, recent experience, the Affordable Care Act, the numbers are there, they're accurate. 4 years, 230% increase in health insurance price. We had a panel on drug pricing 2 weeks ago, and the panel was unanimous that this country is the most innovative country in the world in drug innovation. Do y'all all agree with that? Anybody argue with that? And I think one of the reasons is because of the patent protection we provide. Mrs., I don't know how to pronounce your name, Kaczynski? Kapczynski. You are a patent intellectual property lawyer, correct?
I'm a law professor, but yes, I mean, I study intellectual property law and patent law.
And you sound very adverse to intellectual property protection. Do you not believe that this intellectual property protection that we grant to pharmaceutical companies has spurred this remarkable, innovative market that we have in the United States?
I think the reason we have such an innovative industry is in part that we put a lot of money from the government side into innovation, and there's evidence that the most path-breaking, most risk-taking research is actually done by government, right? And then industry does play a role, and patents do play a role. I think the problem is that
Okay, so how would you modify the patent protection that we have now? Would you lower the number of years off the bat that a company gets?
Well, I think there's ways to tighten up the standards, right? To say we're not going to give so many, trivial patents for trivial innovations. We should give patents only for more serious innovations. But I think at the end of the day, the other reality that you have to say is patents they do function like monopolies. And so, you can be in a standard intro to economics course
I get
and
very
people
mixed
say,
messages from you. I would like to know specific changes that you would like to see in the intellectual property arena. Mr. Holtz-Aiken, do you agree that there needs to be changes in the intellectual property arena for prescription drugs?
So the issue is a very simple one of trade-offs, which is at any point in time, once you have an invention, the economically desirable thing to do is to have as many people use it as possible, and that means get rid of the ability to do monopoly pricing. The trouble is, you then don't get the innovation to begin with. And so you have a trade-off in engendering innovation and then the pricing of that innovation afterwards. So I can't tell you the right number of years of patent protection to get the right amount of innovation.
So we've got to find this middle ground. And patent protection is just one part of the problem. There's a lot of perverse incentives in the way Part D is administered.
I would start with a lot of the others first.
The percentage reimbursement to physicians and hospitals drives them to the most expensive drugs. The reinsurance program appears to be a huge problem. So there's a lot of things that we can do, because there are a lot of really bad examples here. I would never argue that there aren't really bad examples. One problem I see, one huge problem, I'll go to you, Mr. Asasi, is I have a lot of dentists in my district who they used to give doxycycline or some type of antibiotic to their patients before they did the work, because it gets into an infection could get in their bloodstream. Then it was so cheap, it was $5, it was out of protection, they would give it to them. And now this same prescription costs $100. And it's not because there's some type of patent protection, it's because it's so cheap that nobody wants to make it, right? So how would you fix that problem?
Yeah, and you're pointing to a really good example, the fact that I think nobody here is hostile to the idea that the free market should be operating and we should create competition. And the problem we have is that government-granted monopolies are written in a flawed way, and we have these pharmaceutical companies abusing that.
What I'm telling you is these things have no patent protection. There is no government-provided monopoly.
In this case, the point is they make a lot more money by sort of going down a rabbit hole of making a small change to a drug than they would by producing these antibiotics that we need as a country. And a lot of this is about the fact they're chasing the high-margin insured patient. So they're trying to find those drugs that can make a small tweak, and I've got cancer now, I'll spend $50,000 a year, instead of the exact drug you're talking about, which is, the number one example is the one you're giving, which is we need new antibiotics that aren't resistant, right? And no one's developing them because the incentives that we're creating through this patent law doesn't actually serve the public interest. It serves the interests of the pharmaceutical companies.
Thank you very much. Your time has expired, and I will conclude with my own questions. I view it as encouraging that there is bipartisan recognition of the serious problems so many Americans are facing with really prescription price gouging. The question is whether we'll have any bipartisan agreement on doing anything about it, and that remains far uncertain, particularly with regard to the last round of questions. Now, there's some things we could do about this problem. We could write a nice letter, a very respectful letter to Big Pharma, and ask them to please lower their prices so that victims all across this country wouldn't suffer. We could say pretty please with sugar on it, which is basically what President Trump did in his Rose Garden press conference. And he did manage to delay some price increases for all of 6 months, but the prices have continued to rise. Anyone who believes that pharmaceutical monopolies will yield their monopoly profits, which are extraordinary, just for the public good, has not observed with any level of objectivity the performance of this industry over recent decades. I favor a bipartisan solution. Indeed, all I want is for President Trump to follow the advice of candidate Trump, who said that bidding would save this country hundreds of billions of dollars. It is surprising to hear from the outset that our Republican colleagues reject any backstop to negotiation. They do not offer any alternative to lower the prices that Americans are paying for their drugs. They only criticize the alternatives that have been advanced in the past. Now, one of those alternatives, referred to as the heavy hand of government, just happens to be the way that veterans who have served our country all over America get their pharmaceuticals for reasonable prices today, because the Veterans Administration uses a formulary. And in some areas, we have had effective formularies in the private sector that have helped to bring down prices. But our Republican colleagues reject the idea of a formulary and say it will deny life-saving drugs to some Americans, even though it seems to have worked rather effectively for the veteran population. And in view of their objections voiced before today, I've offered an alternative called competitive licensing. And it has been really extraordinary to listen to the criticism of it. On the one hand, it is theft and confiscation, and there are no rights for those whose property is taken. And on the other hand, their witness tells us one of the problems with competitive licensing is that it will be tied up in the courts for years, because what that plan provides is if the pharmaceutical company will not negotiate in good faith, they're entitled to fair payment for the royalties and the licensing rights, not the taking of anyone's property, but the fair payment for their rights, and then they have a judicial remedy if they don't think that fair payment was fair. And let me ask you, Professor Kapczynski, about, given all of these extraordinary comments that we might be denying people the right to go to church under this approach, have the socialists and those who want complete government control during Republican administrations, have they ever used the concept of licensing in other areas in order to assure that our military had the equipment that it needed? Have they used essentially the same approach that I propose in this competitive licensing bill?
Absolutely.
Can you speak up just a little bit? I want everybody to hear your answer after all of this condemnation we've listened to.
Absolutely. This approach is used all the time, right? There are examples where government patent use has been used to procure lead-free bullets, passport scanners, right? There are many, many examples that we have of this, because this has existed in law for 1940s, the law was passed, and prior to that, government patent use actually, you could never sue the government for patent infringement. So yes, it's been used all the time. And it is used now, even currently. There's a lot of examples in defense, but not only in defense, where government's procuring. You say, government procurement officer, just procure at the lowest price, and then you get compensation, as you say, which is a really critical part of the story.
And I'll ask both you and your colleague from Harvard, you've looked at the factors in the bill that outline both how prices would be determined as a fair price for the drug, but also how would someone who refused to negotiate and is then told that a competitive license would be granted so that generic competition could come in and we could rely on American competition to drive prices lower. Are those factors fair? Are they the factors that need to be considered, or are there others that should be considered?
So I would say those factors are fair, and critically what we're talking about here is rewarding companies for transformative innovation. One of the two of the essential criteria that would be factored in the compensation that a manufacturer would get is the comparative effectiveness and safety of the drug. And in that case, if a manufacturer brings a good drug to market, it will get handsomely rewarded. And in terms of the questions as to how do we decide there are plenty of schemes that are available in terms of determining what the value of a drug is, and there are plenty of countries that use that scheme quite effectively.
You have anything to add on that?
No, I think that I take the same position.
Well, let me ask you as well, because the other argument that has been made that I find really incredible is the defense of Big Pharma on its record of innovation and on its response to the needs that we have for new treatments, new cures, noting, as I think one of you may have done, that in 2017, the Government Accountability Office found that only 13% of all the new drug approvals were actually innovative drugs. They are masters in innovation when it comes to extending monopoly pricing for decade after decade. But when it comes to innovation and finding the cures that Americans need, isn't it correct, Doctor, that they have a pretty sorry record? And I would ask you in responding to also address this question of research into how effective drugs are in comparison to each other and what role comparative effectiveness should play.
So at the outset, I want to agree with Dr. Holtz-Eakin that science is incredibly difficult and this is a risky proposition. But I think this statistic points out a little bit of the innovation struggle with industry right now. Markups on existing drugs accounted for 60% of the U.S. drug revenues between 2014 and 2017. How the industry is sustaining itself is through price increases right now. And in terms of the drugs that are coming to market, I think it's important that we consider that not all of these drugs are actually that good. And I can go into statistics about showing about the value of these drugs, but just the sign of FDA approval does not mean that the drug offers a remarkable benefit. Increasingly, the FDA is approving drugs on the benefit of surrogate outcomes, and that surrogate outcomes are later tied to hard endpoints that show that they don't actually improve those hard endpoints. Critically in all of this, and I've tried to make clear in this testimony, is really where you're looking at the driving force of innovation is U.S. government-funded research. Now, does that not mean that pharmaceutical companies are doing an important job in this market? Yes, they are. They're doing a critical job. It is risky, but when we talk about innovation and the sources of innovation, we need to recognize that that wellspring is really the federal government funding public sector research institutions.
I want to thank all of you and all of our colleagues. There's obviously vigorous debate about this. I would just close in returning to my opening comments that we have a system where the taxpayers fund much of the research, the government grants a monopoly in defiance of the free market, and then there is no restraint against price. It's whatever a sick or dying person will pay for a little more time or a little relief. That system, relying on monopolies the government has approved, is not innovating, is not meeting our needs, and we need to find ways to deal with it. I think it will take more than just tweaking the system in order to solve these problems, but I look forward to our continued engagement and work on this subcommittee and the full committee. And with that, our hearing is closed. Thank you.